Hello everyone. Welcome to the presentation of our research on the implementation of the MARSIPAN Guidelines by UK Dietitians. My name is Stefanos Pagonidis and I'm presenting on behalf of my colleagues Mirela Velikova and Paula Esquinca. Our research project was conducted at UCL and was submitted in late 2019. The supervising professor was Dr. Paul Robinson of the Master's degree in Eating Disorders and Clinical Nutrition. To start off with, I'm sure that many of you have heard of the MARSIPAN Guidelines. They were published by the Royal College of Psychiatrists in the first half of the decade we've just crossed, and the name stands for Management of Really Sick Patients with Anorexia Nervosa. Their aim is to provide recommendations on how to assess, refer, and treat cases of anorexia. The NICE guidelines also have publications on the same subject, yet the MARSIPAN team tried to identify and solve gaps in the NICE guidelines. Heading off to our introduction, eating disorders are on the rise. In the years 2018 and 2019, there were 19,040 admissions of eating disorder cases in UK hospitals. These numbers reflect a steady annual increase of 3,000 cases, making eating disorders a pressing issue of our time. To add into the matter, anorexia, as a mental health disorder, is a relapsing eating disorder and has the highest mortality rate among all mental health illnesses. Moreover, in recent years, there have been calls across different research groups and clinicians to identify those whose symptoms are acute and do not recover in the long term as experiencing severe and enduring anorexia. However, there is no generally accepted definition of the term yet. And Dr. Paul Robinson suggested in 2009 that the definition of SEEDAN, SEED anorexia nervosa, should involve both chronicity and severity of the disorder. According to Dr. Robinson, anorexia should be considered chronic if its duration is longer than 10 years and severe if its symptoms significantly impair the quality of life of the patient and their family members. Therefore, the MARSIPAN came to be the clinical guidelines which were introduced due to the underlying concerns about the deterioration of the inflicted patients when admitted to medical wards. When firstly introduced, the MARSIPAN guidelines were specifically developed for adults over 18 years old, and there is age and gender-related variation in weight range and risk assessment measures. Moreover, different legal frameworks are used to address consent and capacity among children and adolescents, and the services for that part of that population have different structures than the ones for adults. As a result, the junior MARSIPAN was later formulated and covers the management of young people with severe anorexia under the age of 18. When it comes to key issues, the MARSIPAN guidelines involve a module on risk assessment, information on compulsory admission and treatment, and recommendations on the location of care. And since this study focuses on dietitians, with respect to the dietetic input, the MARSIPAN guidelines highlight the vitality of nutritional training provision in the treatment of eating disorders and recommend that in cases where there is no dietitian skilled in refeeding within the medical team, the team should contact the closest specialist eating disorder unit in order to develop a refeeding protocol for such patients and work together whenever receiving eating disorder admissions. Moreover, the MARSIPAN guidelines emphasize in general in the importance of nutrition support teams in the provision of care of patients with eating disorders and recommend that all acute wards have such a team. Now, looking at the research questions, this study aims to answer 3 questions. Since no study has focused exclusively on eating disorder specialist dietitians, this study aimed firstly to reveal how many UK dietitians working in eating disorders implement the MARSIPAN or the junior MARSIPAN guidelines, and to what degree an overlap with other guidelines already exists, for example the NICE guidelines. The second aim was to study the extent and the precision in the implementation of the MARSIPAN and junior guidelines by these dietitians. And lastly, since the studied group of this research consisted of eating disorder specialist dietitians, a demographic description of the provision of this dietetic speciality area was attempted to be described. As noted above, only a few studies have investigated the implementation of the MARSIPAN guidelines so far. These studies, which are mentioned on these slides, are not extensive and only try to offer a first insight into the matter. Given the high mortality rate and the chronic nature of anorexia nervosa, further investigation into the treatment and management of this illness are required in order to increase treatment effectiveness and reduce mortality rates. Therefore, the present study aims to examine the implementation of these guidelines across the UK registered dietitians. It is the first study in this subject and the first one to focus exclusively on dietitians. Looking into the study group, the elimination criteria were the following. All participants ought to be UK registered dietitians practicing either full-time or part-time in the care of eating disorder cases. As per the clinical settings, NHS, private hospital settings and charities were all included in the study. Given the different provision of services in eating disorders, all inpatient, outpatient and daycare services were included into the study. Since care provision in eating disorders is separated in adult services and child and adolescent services, both of them were included into the study. As per the geographic area studied, England, Scotland, Wales and Northern Ireland were all included into the study. Regarding the collection of data, a questionnaire was formulated. It was comprised by 41 different questions and its format was based on 2 previous studies aimed to address the implementation of the MARSIPAN guidelines. The questionnaire was delivered to participants online and this made its completion easier and quicker. Moving on to the results of our study, 177 dietitians were contacted and 62 took part. 58 answers met the inclusion criteria and were analyzed in order to extract the outcomes of the study. The response rate was 32.77%, which is similar to the response rate in similar studies conducted before this one. As per the distribution on the map, here is a map reflecting the participation per county. Overall, the metropolitan areas were very well represented, and more specifically, Scotland and Northern Ireland made up 5.66 of the total representation. Wales unfortunately didn't make it in since there were no answers received. That means that 94.34% of the participants were from England, and looking at England itself, 36.36% were from London and 63.64% were outside London. With regards to participation by sector, the NHS-based dietitians were 70.7%, while private sector dietitians were 29.3%. Regarding the age group treated by these dietitians, 52.2% said that worked with adults, 29.3% with children and adolescents, and 50.5% with both. When it comes to the type of treatment offered, 58.62% of the participants worked on inpatient units, 41.38% on daycare units, and 67.24% on outpatient. Of course, these percentages don't add up since the service settings where the participant was employed can be offering more than one treatment options. Now let's move on to our findings. We've asked the dietitians if they have heard of the MARSIPAN guidelines, and 100% said yes, which is definitely a positive remark. And when asked if they use MARSIPAN, if they use the MARSIPAN or the junior MARSIPAN guidelines, 41.7% said that they are using the adult ones, 28.3% the junior ones, and 25% both. So in total, 95% of the participants were following the age-appropriate MARSIPAN guidelines. What is interesting is that 74.14% of the participants said that they use the MARSIPAN guidelines in conjunction with other guidelines. These other guidelines were mainly the British Dietetic Association guidelines and the local trust guidelines, as seen on the table over here. Also, 50% of the participants admitted that they are following the NICE guidelines too. This means that they were following both the MARSIPAN and the NICE guidelines at the same time. It is worth mentioning that the NICE guidelines present some different recommendations to the MARSIPAN ones. For example, when it comes to the rate of refeeding introduction, NICE recommend a less aggressive calorie prescription than the MARSIPAN. With regards to the training provision, interestingly, only 37.9% of the participants had received marzipan-related training, with a majority of the 62.1% saying that they have not. And going back to the rate of refeeding, now in detail, out of all the participants, only 32.76% followed the marzipan guidelines initiating refeeding at 20 calories per kilogram per day. Even less appeared to be following the NICE guidelines of between 5 and 10 calories per kilogram per day. And most of them, 37.93%, tended to follow an even more aggressive approach to initiate refeeding, which does not follow any of the known guidelines. On the good news, the majority of the participants agreed upon the rate of increasing the intake of refeeding, with that being 200 calories per day, which is in accordance to the marzipan guideline suggestions. Continuing with the good news, most of the dietitians seem to be following the marzipan guidelines in the aspects of risk assessment and patient monitoring. All the above give the sense that the marzipan guidelines are overall well respected and followed by UK dietitians. Now let's have a look at the conclusions. This study concluded that since many dietitians follow an aggressive refeeding initiation pathway, which is a recommendation outside the known guides, this might call for a review of the existing guidelines. Also, according to the data collection, there is a need for more eating disorder services in localities outside London, since eating disorder services provision there is smaller. Regarding dietetic involvement in eating disorders, most eating disorder dietitians working in community and outpatient settings or working part-time believe that there is not sufficient dietetic input within their team. This raises a concern over how adequate the provision of dietetic employment is. And lastly, the study concluded that marzipan training should become more available since the majority of the participants didn't have received the appropriate training. So, considering the results mentioned just now, this study presents with some limitations. It seems that further research should examine the reliability and validity of the survey used in the present study. Moreover, future studies should implement survey strategies such as pre-notification and inclusion of QR code in order to increase the response rates of the participants. Further studies should also involve more members of the multidisciplinary team required in the treatment and management of anorexia, included but not limited to physicians, pediatricians, psychologists, psychiatrists, and nurses, in order to identify issues and advices for improvement. And lastly, the study did not collect any gender information or years of practicing experience of its participants. This information might provide a more detailed analysis in any future research in this subject. So these are some of our references. I hope you enjoyed this presentation. On behalf of my colleagues, I thank you for your time. Have a good day.